Well, good morning, or good afternoon, or good evening, depending on when and from where you're joining us. I'm Dr. John Iskander. It's my pleasure to welcome you to CDC Public Health Grand Rounds for September 2016. Public Health Grand Rounds has continuing education credits available for physicians, nurses, pharmacists, veterinarians, health educators, and others. Please see the Grand Rounds website for more details. Grand Rounds is available on all of your favorite web and social media sites. We're also live tweeting today. Use hashtag CDC Grand Rounds. We have a featured video segment on YouTube and our website called Beyond the Data, which is posted a few days after the session. This month's segment features my interview with Dr. Stuart Shapira. And we've also partnered with the CDC Public Health Library to feature scientific articles relevant to this session. The full listing is available at cdc.gov/scienceclips. We're currently conducting a brief survey about public health grand rounds, and we'd love to hear from you. The results of the survey will directly contribute to series improvements. A link to the survey can be found on our website, and your participation is greatly appreciated. Here's a preview of some upcoming Grand Round sessions. Please join us live or on the web at your convenience. So in addition to our outstanding and I must say good-looking speakers today, I'd also like to acknowledge the important contributions of the individuals listed here to this session. So before we get started, it's my pleasure to introduce CDC's Principal Deputy Director, Dr. Ann Schuckett, for a few remarks.
Good afternoon, everyone, and thanks for joining us for what looks like it will be a terrific Grand Rounds. This is really timely. Many other CDC staff are huddled in a building near here, focused on a new threat to newborns and their long-term development. And so it's very timely for us to revisit newborn screening and learn about what's new and what the future holds. In 1963, President John F. Kennedy said that the needs of children should not be made to wait. Newborn screening began in the U.S. in the 1960s to identify severe medical conditions that may not be clinically apparent at birth. Newborn screening is considered one of the greatest public health achievements. It reaches 4 million children in America each year, leading to life-saving treatment and intervention for at least 3,400 newborns with selected genetic and endocrine disorders. Newborn screening was initially done by Bloodspot testing only, but as you're going to hear more recently, it's expanded to include early hearing testing and critical congenital heart disease screening. Identifying newborns with hearing loss and intervening as early as possible has benefits for schools and communities that are shared by all of us. Timely diagnosis and early intervention for deaf and hard of hearing infants improves language development and school performance. State and territorial early hearing detection and intervention programs document that in 2014, over 97% of U.S. infants were screened for hearing loss. But, as in so many of our programs, more progress is still needed to ensure that infants who do not pass hearing screening receive the diagnostic evaluations and timely diagnosis of hearing loss that they need. Timely diagnosis of congenital heart disease saves lives, but this is a newer program. New Jersey was the first state to pass and implement universal critical congenital heart disease screening, and today you're going to hear directly about their leadership and their dramatic experience. Our speakers today will give special attention to methods for measuring the success of these newer types of newborn screening, which include documenting improved health outcomes resulting from early identification. You'll also hear about how health information technology standards and systems linkages can facilitate electronic reporting of test results, reduce the burden of reporting public health data, and improve the completeness and timeliness of reporting for infants who don't pass screening. CDC and our partners are working to quantify the long-term educational and economic benefits of early hearing detection and intervention and promote more complete reporting of critical congenital heart disease screening, and linkage with birth defects surveillance systems. So let's go on with the show.
Our first speaker will be Dr. Stuart Shapiro.
Thank you, John. I will begin with a very brief history lesson, followed by an overview of point-of-care newborn screening. Newborn screening is one of the most successful public health programs. It benefits neonates and families from early diagnosis and treatment of the screened conditions through cost-effective approaches. Through its first 4 decades, specific criteria determined whether conditions were amenable to newborn screening, including the availability of a reliable screening test that could be applied at a population level and a system to follow up screen-positive newborns. In dried blood spot screening, blood is obtained from neonates via a heel prick at 24 to 48 hours after birth, spotted on filter paper cards and air-dried. The filter paper cards, which also contain demographic, sample collection, and contact information, are shipped to a centralized newborn screening laboratory for testing. Results from the screening analyses are reported centrally to state health departments. Positive screens are followed up. Up until 2005, the number of screened conditions varied significantly between states. In 2005, the Secretary's Advisory Committee on Heritable Disorders in Newborns and Children recommended that 29 conditions make up the original Recommended Uniform Screening Panel, or RUSP. All except congenital hearing loss are screened through dried blood spots, with hearing screening being the first condition under the point-of-care screening paradigm. Since the acceptance of the original RUSP, there have been 5 new conditions approved by the Advisory Committee through evidence review and subsequently approved by the HHS Secretary. All 5 conditions are screened from dried blood spots except critical congenital heart disease, which is the second point-of-care screen. Just as nationally notifiable diseases must be made reportable to state health departments, it is still up to states and territories to enact newborn screening requirements via laws or other means to begin screening for conditions added to the RUSP. Traditional blood spot screening uses blood collected by pricking the newborn's heel, but now there is this newer paradigm, point-of-care screening, which is utilized for 2 conditions, congenital hearing loss, which is coordinated through a national program known as Early Hearing Detection and Intervention, or EHDI, and critical congenital heart disease, or CCHD. The goals are the same as for blood spot screening: the timely identification of every baby with the condition and getting him or her into the appropriate interventions. However, the processes of these newborn screening paradigms differ, leading to unique challenges. As I've defined them on this slide, you will hear the acronyms EHDI and CCHD throughout today's presentations. Point-of-care tests are performed at the birthing facility, typically at 24 to 48 hours after birth, but before discharge. And newborns who do not pass the screen are referred for diagnostic testing. Since point-of-care screening is not conducted centrally, but rather at thousands of birthing facilities, this results in difficulties monitoring screening effectiveness, such as the number of true and false positive screens and the number of infants not identified by newborn screening, but detected clinically. Congenital hearing loss is the most common condition identified by newborn screening in the United States. Over 97% of neonates were screened for hearing loss in 2013. The incidence that year was 1.5 per 1,000 neonates screened. However, this incidence estimate cannot account for infants who fail the newborn hearing screen, but lack confirmation of follow-up diagnostic testing to either confirm or exclude the diagnosis of hearing loss. In 2013, this loss to follow-up or loss to documentation rate for neonates who did not pass the initial screen was 32.1%. Screening for congenital hearing loss is conducted through a non-invasive test, either the automated auditory brainstem response test shown in the upper photo, or the otoacoustic emissions test shown in the lower photo. Newborns who do not pass the screen in one or both ears are referred for a diagnostic hearing test by an audiologist after discharge. The Joint Committee on Infant Hearing outlines guidelines for screening and referral, namely that all infants are screened no later than age 1 month. All infants who do not pass the screen have a diagnostic test no later than age 3 months, and all infants with confirmed hearing loss receive appropriate intervention no later than age 6 months. To help achieve the 1, 3, 6-month goals, every state and U.S. territory and the District of Columbia have an EHDI program. The EHDI programs support families of children identified with hearing loss. They collect individual level data on infants in the state or territory and whether they meet the 1, 3, 6-month goals, and they report aggregate data annually to the CDC. CCHD, the other point-of-care screening condition, has a significant risk of mortality. Prior to the institution of newborn screening, one study showed an infant mortality rate of about 18%. CCHD is more common than congenital hearing loss, with an estimated incidence of 2 to 3 per 1,000 live births. However, most newborns with CCHD are identified prior to newborn screening, either prenatally or because early neonatal symptoms or a heart murmur prompted a diagnostic echocardiogram. Therefore, the estimated newborn population with CCHD potentially detectable by newborn screening is about 4 per 10,000. Unlike for congenital hearing loss, there are yet no national data available for the incidence of CCHD identified by newborn screening or the false negative rate. Screening for CCHD has been part of the RUSP since 2011. This non-invasive screening is conducted by placing a pulse oximeter on the right hand and 1 foot. The pulse oximeter indirectly monitors the percent of the newborn's blood that is saturated with oxygen. The typical normal range of oxygen saturation is 95 to 100%, with no more than a 3% difference between the measurements in the right hand and the foot. Oxygen saturation is typically lower than expected in the presence of any of the critical congenital heart defects. The oxygen saturation values in the hand and the foot are evaluated by an algorithm to determine whether the screen was passed or whether a repeat screen or a diagnostic test is indicated. The 12 heart defects that cause CCHD are provided here. While the non-invasive screening is optimized to detect CCHD, some non-critical congenital heart defects, as well as some non-cardiac causes of low blood oxygen saturation, might be detected as well. All of these secondary targets of screening can benefit from early diagnosis and treatment. Newborns who do not pass the screen are immediately referred for an echocardiogram, which is an ultrasound imaging study of the heart. One challenge for CCHD screening is that many birthing facilities do not have on-site access to echocardiography or to a pediatric cardiologist, which would necessitate the transfer of the screen-positive newborn to another facility. Other higher-level challenges for CCHD screening relate to the fact that this screening program is not as mature as the newborn hearing screening program. All except 2 states currently have universal CCHD screening, but there is no EHDI-like program for CCHD. Not all states collect screening data. Among the states that do collect data, the data elements vary from state to state. And states also differ as to whether data are collected on all screened newborns or on just those with a positive screen result. Keeping in mind the various challenges, then what is the role of public health in point-of-care newborn screening? The state and territorial EHDI programs, as well as HRSA and CDC, have been instrumental in supporting congenital hearing loss screening. Activities include providing consultation, coordination, and technical assistance to improve all aspects of hearing screening, collecting and organizing data for evaluation of screening effectiveness and quality assurance, evaluating the impact of newborn screening on short and long-term outcomes, such as improved development and school performance, and providing support for affected children, families, and their health providers. Public health must have similar roles in CCHD screening, but it will take some time and effort to get there. Coordination at a national level can accelerate the process. Our next speaker, Marcy Sontag, will elaborate on the crucial role of federal partners.
Thank you, Stuart. I will be speaking about the landscape of hearing loss and congenital heart disease newborn screening at the state level and the collaborative role of federal participation. I will present current activities to support newborn screening for both hearing loss and CCHD through implementation, data collection, technical assistance, and quality improvement. Universal screening for early hearing loss was not a rapid process, but rather took much support from many organizations to implement. Currently, all states are offering universal screening for early hearing loss through structured programs, although the processes and support structures are varied. CCHD newborn screening had very rapid implementation since 2011. Through the coordinated efforts at the local, regional, and national levels, most states have universal screening for CCHD, although the development of CCHD programs is limited. All states are universally offering screening for hearing loss, but it was a long process to get to this point. Beginning in 1990, with only 2 states, 13 years passed before all states developed comprehensive EHDI programs. EHDI programs found their roots at the local level and gained strength through the years to reach the well-established multi-agency programs we have today. In contrast, CCHD screening implementation began later and was relatively rapid. In 2012, only 5 states were screening for CCHD. An additional 20 states began offering universal screening in 2013. And by 2014, 40 programs offered universal screening for CCHD. All but 5 programs were offering screening in 2015. And currently, all but 2 states are offering universal screening for CCHD. Wyoming has recently approved CCHD newborn screening with a January 1st, 2017 start date. To really understand the nuances of CCHD and early hearing loss newborn screening, we need to look carefully at the legislative requirements. In some cases, newborn screening is mandated, with no provisions for data collection, while in other cases, screening is universally offered in the absence of a requirement, but the state public health department oversees data collection and quality improvement activities. Details of the nature of the legislative and regulatory approval for each of the newborn screening programs reveals interesting parallels. Congenital hearing loss screening is required in 46 programs, 30 programs through legislative mandates, and 16 through rules or regulations without specific legislation. 5 programs support EHDI screening through standard of care. Quality newborn screening systems must include mechanisms to collect and evaluate data. Early hearing loss data collected at the hospital level are required to be reported to public health systems in 36 states. Even in states with no specific data requirements, programs have developed mechanisms to collect data through the electronic birth certificate, dried Bloodspot card, or other electronic reporting systems, resulting in data collection at the state level with subsequent reporting to national data systems in all state programs. While only 30 states have early hearing loss newborn screening legislation, 41 states have active legislation related to newborn screening for CCHD. 8 states require CCHD screening through rules and regulations. 2 states support screening within their hospitals through standard of care but do not require screening. One state, Kansas, supports screening through standard of care and has developed a system to collect screening outcomes on all infants, even in the absence of legislation to mandate screening. Most states have requirements to collect CCHD screening at the Department of Health, but 15 states have no requirements for data collection. The type of data collected within each state also varies, with some hospitals reporting all screening values and times, while other hospitals are only reporting aggregate data, such as the number of newborns receiving screening and the number who failed screening. The differences in data reporting to public health programs between CCHD and EHDI programs is amplified nationally, where EHDI programs are supported by integrated efforts across agencies, and CCHD screening support is still developing. Hearing loss and CCHD are both reportable conditions, and the Birth Defects Prevention Network, supported by CDC's National Center on Birth Defects and Developmental Disabilities, can be utilized for surveillance purposes to identify newborns with early hearing loss or a critical congenital heart defect. This can help to better understand the impact of these screening programs and to determine the efficacy of the screening programs. HRSA provides technical assistance for both hearing screening and CCHD screening. HRSA also financially supports state EHDI programs. Early funding from HRSA was offered to 6 programs to demonstrate the capabilities and challenges of CCHD newborn screening implementation. Congressional funding support for early hearing loss newborn screening totals over $26 million, with $10.8 million appropriated to the CDC. CDC provides direct assistance to 45 state EHDI programs. The funding is used to support activities related to improving screening processes, decreasing loss to follow-up in children with failed hearing screens, and tracking long-term outcomes in children with hearing loss. CDC's technical assistance also includes the EHDI Dash, an interactive online tool that presents annual data from states and territories for infants screened for and diagnosed with hearing loss. The EHDI Dash map displayed here shows the percent of newborns that are reported to have been screened in each state. The network of technical assistance and informatics support will be discussed by Dr. Mason. Congressional appropriations to HRSA for hearing loss screening total $17.8 million. HRSA has funded 1 technical assistance center that is dedicated to early hearing loss newborn screening. The goal of this program is to ensure all children with hearing loss receive appropriate and timely identification and treatment. The Resource Center includes videos, telehealth courses and guides, and technical assistance activities. NCHAM supports activities to reduce the loss to follow-up of infants who have not passed a newborn screening examination prior to discharge from the newborn nursery. All states receive funding to support their EHDI programs via HRSA or CDC appropriations. When we examine the data and resource environment for CCHD screening, a different picture emerges than for the more developed EHDI programs. These differences are best summarized in the areas of data collection, federal assistance, and resource allocation. The American Academy of Pediatrics recently published lessons learned from newborn screening for CCHD. Despite widespread implementation of CCHD screening, a common challenge is limited funding across all programs. While the cost of screening is borne by the birthing hospital, additional funding is needed to support education of parents and healthcare providers, infrastructure for data collection, and quality assurance activities. There are a few key limitations to CCHD data collection at the state level. There is limited local data, frequently collected in aggregate, and data collection has only recently begun in many programs. National standards for data collection have only recently been presented, resulting in varying data collection. Data systems within the public health departments are limited by both funding for staffing and a lack of data infrastructure. The report recommends the optimal data set for CCHD surveillance at the state level, which would give a strong foundation for data collection and analysis at the national level and provide vital information to make sound evidence-based recommendations. HRSA's New Steps program is the National Resource Center for Bloodspot and CCHD newborn screening. New Steps provides technical assistance, quality improvement support, and a data repository for the conditions identified through dried blood spot and point-of-care newborn screening. New Steps fosters ongoing collaboration and networking between programs. New Steps Data Repository collects quality indicators from states and case-level data on infants identified by newborn screening to assess the outcomes of screening programs. This case-level data collection is just being introduced to the CCHD community. Support for CCHD surveillance and data collection is at the local level and is the responsibility of the state and hospital, and there are currently no federal funding initiatives to directly support CCHD implementation at the local level. The current programmatic and funding activities that are in place for early hearing detection should serve as a model for CCHD and other point-of-care screenings that are implemented in the future. As I conclude, I would like to compare the follow-up systems and impact evaluation of both programs. While both programs have developed networks with clinical specialists, the public health programs in EHDI are well established, while CCHD programs are still developing. Follow-up for hearing loss occurs entirely after discharge, while CCHD follow-up begins in the birthing facility. Without public health interventions, there would be a high number of infants lost to follow-up after an abnormal hearing screening. Conversely, infants who fail CCHD screening typically do not leave the hospital. Evaluating the programs involves tracking the rate of newborns that are screened and receive the necessary follow-up assessment by a specialist. The ability of the current systems to track and report on the efficacy of both programs is limited. Finally, impact evaluation assesses how newborn screening and subsequent interventions affect long-term outcomes. The more established and nationally funded EHDI programs are able to compare outcomes longitudinally and across programs, while CCHD has limited data and resources to support outcome evaluation. There has been broad uptake of both early hearing loss and CCHD newborn screening. Programs differ with regard to federal resource allocations and data collection issues. However, efforts at the local level continue to support data collection and program improvement. The evaluation of both the short and long-term follow-up of infants is critical in assuring that quality screening programs identify at-risk infants and move them into appropriate care. New Jersey is one state that has developed a model program for CCHD newborn screening. I am pleased to introduce Dr. Kim Van Ardenbron, who will be presenting on New Jersey's implementation of CCHD screening.
Thank you, Dr. Sontag. As a CDC assignee to the New Jersey Department of Health, I've been fortunate to work closely with New Jersey's dedicated staff on the implementation and evaluation of their statewide critical congenital heart defect screening mandate and surveillance program. As you've heard, relative to other long-standing newborn screening programs, screening for CCHD is in its early stages, particularly related to data collection and surveillance. My goal is to share the evolution of our experiences in New Jersey, particularly with respect to surveillance, the lessons we've learned, and the questions that remain. On June 2nd of 2011, New Jersey Governor Chris Christie signed legislation mandating that each licensed birthing facility in New Jersey perform a pulse oximetry screening at a minimum of 24 hours after birth on every newborn in its care. This unfunded mandate required that statewide implementation occur within 90 days. New Jersey was the first state in the nation to both legislate and implement CCHD screening statewide. The New Jersey Department of Health quickly sprang into action in the summer of 2011 to develop and disseminate a screening algorithm, train birthing facility staff, and create mechanisms for data reporting to monitor and evaluate the unique contribution of the statewide mandate on early detection of CCHD. On September 1st, 2011, a day after the law became effective, in preparation for discharge home, baby Dylan Gordon received the newly mandated CCHD screening. After failing the screen and the resulting diagnostic evaluation, it was determined that Dylan had a previously unrecognized critical congenital defect and needed life-saving surgery. This outcome might have been very different in the absence of the CCHD screen. In a letter to Governor Christie, Bill and Lisa Gordon wrote, "It's because of your law that our son's life was saved. Our son Dylan is proof that the test is worth doing." This immediate evidence of the CCHD screening's life-saving impact further motivated all involved to create a mechanism to monitor the mandated screen. New Jersey was eager to know how many more wonderful stories like Dylan there would be. We explored the state's existing data collection mechanisms to determine whether data fields could quickly be added without additional funding. This included the newborn Bloodspot card, electronic birth record, immunization registry, and New Jersey's birth defects registry. We found that the crucial component for establishment of the New Jersey CCHD Screening Surveillance Program was bridging newborn screening with birth defects surveillance. In 2011, New Jersey DOH was developing its new electronic birth certificate platform. Therefore, our goal of individual-level screening data needed to be a part of a longer-term plan. To assess screening coverage rapidly, we created a one-page form for each birthing facility to submit aggregate screening data quarterly. The new Vital Information Platform, or VIP, was rolled out statewide in 2015 and is a rich source of individual-level screening data. Upon implementation, concerns were voiced by the medical community regarding a potential added burden on clinicians and hospitals due to false positive screens. This reinforced that we needed to understand not only the program's successes, but the characteristics of all failed screens and the implications on resource burden. We were able to add a module to New Jersey's long-standing birth defect surveillance infrastructure to capture all failed screens, regardless of their final diagnosis. A series of questions were developed and field tested to capture the relevant clinical information needed to evaluate the unique contribution of screening to early detection of CCHDs. The NJBDR has proven to be a very effective method for CCHD screening surveillance. The aggregate data form and quarterly submission process enabled us to assess screening coverage quite quickly. From the inception of implementation on August 31st, 2011, through December 31st, 2014, 99.7% of eligible infants born in New Jersey birthing facilities were screened. The proportion of infants screened has been extremely high since the first quarter after implementation. The small proportion of missed screens in the first quarter of 2011 was driven in large measure by a misinterpretation of the legislation that infants in the neonatal intensive care unit were exempt from screening. In New Jersey, all newborns are mandated to be screened regardless of their clinical status or location. Since the beginning of 2012 through the end of 2014, less than 0.4% of eligible infants were not screened. Birthing facilities report all failed CCHD screens to the NJBDR. Healthcare professionals are required to register infants with a CCHD who are New Jersey residents, and we built upon this practice to include all failed screens. The NJBDR staff's relationships with each of the birthing facilities supported the rapid implementation of this new module. Data from this module are reviewed by the core CCHD team on a monthly basis. Follow-up with hospitals is done when needed to clarify an infant's clinical course, and a separate database is populated with the clinical data for analytic purposes. Quantifying the screening program's unique contribution to early identification is complex. As mentioned by Dr. Shapira, 3 other methods, including prenatal ultrasound, diagnostic echocardiography, or clinical presentation, contribute to the identification of CCHDs, and therefore information on their presence is needed to evaluate the unique contribution of the pulse oximetry screening. We collected data on these pre-identified factors for all failed screens. We attributed early detection to the screen if an infant failed the screen without any of these 3 factors. Since August 31st, 2011, 295 infants have been registered in the BDR with a failed CCHD screen. Approximately 45%, or 133 of all registered fails, did not have any of the 3 pre-identified factors described previously. 25 infants had a CCHD that was unsuspected prior to the screen, or approximately 1 infant every 2 months since implementation. Through surveillance, we're able to quantify how many more infants like Dylan have benefited from the CCHD screening. In addition to the 25 infants with unsuspected CCHD, we identified 19 infants with previously unrecognized non-critical congenital heart defects and 10 infants with other significant non-cardiac medical conditions that caused hypoxemia, such as sepsis and pneumonia, all of which identified early because of their failed screen. While the immediate impact of CCHD screening is improved survival, early detection brings additional potential for long-term improved outcomes. New Jersey collaborated with CDC to assess the costs to hospitals to screen for CCHD. A study was conducted in a sample of 7 hospitals, and staff were observed performing the screening. Screening took an average of 9 minutes per infant, and the average cost per infant was approximately $14. The same time and motion study method was subsequently repeated in 2 other states and found similar screening times. Because the number of infants who required clinical exams was small, those exams added very little to hospital costs. To date, no analysis has been done of the money spent by state governments in New Jersey or elsewhere. New Jersey's high rate of screening coverage and successful ongoing use of the BDR have gone hand in hand with extensive education and training efforts by DOH in collaboration with New Jersey American Academy of Pediatrics. In addition to the New Jersey recommended screening algorithm and its associated quick guide, New Jersey DOH has created parent information materials in 6 languages and worked collaboratively with CDC to address cost and burden questions. Providing feedback and our findings to New Jersey hospitals and partners has been of high importance, and we continue to strive to keep all parties engaged. The ability to build upon the BDR's existing infrastructure was crucial. A quarterly aggregate data collection form enabled timely evaluation of screening coverage, and the quick dissemination of a standardized tool both assisted with implementation and also served as an internal quality assurance and accountability measure for the hospitals. The need for strong and ongoing communication with New Jersey's birthing facilities continues to be essential for the success of the program. Many questions remain with respect to both implementation and surveillance of CCHD screening, and they're of national relevance as CCHD screening has become near universal in the US. As most states' legislation requires screening all live births with few or no exemptions, when and how to screen specific subpopulations, including infants in the NICU, out-of-hospital births, and high-altitude geographies, has been an important topic of national discussion. New Jersey recently concluded a multi-state evaluation of CCHD screening in the NICU, the results of which are forthcoming. A pervasive challenge across CCHD screening programs is quantifying false negatives, particularly infants with unsuspected CCHD who pass the screen. Linkage of the NJBDR with birth certificate data will enable assessment of one aspect of the potential false positive population, yet considerable resources are needed to evaluate the issue of false negatives, including reach beyond New Jersey borders. Studies are needed to address the national cost and burden of universal CCHD screening. The New Jersey experience demonstrates far fewer reported failed screens and false positives than the current literature suggests. Finally, metrics for follow-up of CCHD screening need to be defined. Should or can benchmarks for follow-up similar to those for EHDI be used for CCHD? As discussed, the timing for intervention, potential sequelae, and clinical and long-term acuity differ from hearing loss. I've shared today New Jersey's experience, but many states have done excellent work implementing CCHD screening. For many states, though, data collection continues to be a challenge. Thank you for your attention, and I'd like to introduce our next speaker, Dr. Craig Mason.
Thank you, Kim. EHDI programs began with universal newborn screening, but have expanded into long-term follow-up. As described previously by Stuart, The 1-3-6-month goals define a process from screening no later than 1 month of age to diagnostic evaluation no later than 3 months of age to early intervention no later than 6 months of age. Following newborns from birth through early intervention requires reliable public health surveillance in order to minimize loss to follow-up and prevent loss to documentation for children needing services. CDC EHDI has taken the lead by supporting the collection and use of quality data. This has resulted in a dramatic increase in the number of infants served at each step of the 1-3-6 process. Screening rates increased from 52% in 2000 to 98% of all births in 2014. The number of infants identified with hearing loss has shown a 7-fold increase to over 6,000 annually, children who previously may have only been diagnosed after missing key developmental milestones. The number of young children with hearing loss in EI has shown a nearly 9-fold increase, helping thousands of children reach their full developmental potential. To accomplish this, EHDI programs collect different data from different systems reported at different points in time. Since 2000, states have moved from collecting aggregated data to collecting and linking child-level data from vital records, hospitals, audiologists, and other healthcare providers. CDC annually conducts the hearing screening and follow-up survey in which states voluntarily report aggregated data on screening, diagnostic, and EI rates, as well as loss to follow-up. However, there can be issues with relying on aggregated data to inform policy. Therefore, in 2010, CDC piloted the EHDI project in which Iowa, Indiana, and Nebraska began reporting quarterly child-level data that was anonymized and yet able to be linked over time. EHDI required states to report data coded in the same way, so CDC developed a validation tool states could use to check the accuracy of their data prior to submission. This is a significant step to improving the quality and value of national surveillance data. Challenges to collecting complete state and national data include structural issues that may impede monitoring. For example, it can be difficult to access EI data based outside of a health department, or to collect data for out-of-state or home births. Lack of standardization and differences in data quality and timeliness can create gaps in EHDI data systems. Once lost at one point in time, a child may remain lost at subsequent follow-up assessments. This creates challenges to using data for surveillance and program improvement. Nevertheless, as seen in these declining rates of children lost at diagnosis, or EI, EHDI has addressed such challenges while documenting improved timeliness and reduced loss to follow-up. I'll quickly describe several strategies that have been used and note how a few states have adopted these to reduce loss to follow-up at diagnosis. Recently, CDC EHDI collaborated with states on a set of functional standards that identify operational, programmatic, and technical criteria programs should incorporate in EHDI information systems. This can help states develop systems that provide complete and accurate data necessary for surveillance and program improvement. The National Data Committee has promoted standardized definitions to improve consistency in reporting. This includes collecting additional detail on EHDI activities, such as whether testing is in process or whether a family is not advancing through the 1-3-6 process. It has also encouraged expanding annual data reporting to create a more comprehensive national picture of EHDI activity and impact. CDC EHDI has furthered this by developing examples of HSFS items to help ensure reliable reporting. EHDI has also promoted electronic data transfer. For example, integrating the healthcare enterprise has published NANI, the Newborn Admission and Notification Information Standard, which is a messaging platform that automates the merger of vital patient admission and demographic data and shares it with designated public health entities. This system is designed to improve the completeness and quality of data by translating hospital information into a format that can be used by EHDI programs. It's also a model that can be adapted by other public health programs, such as CCHD Screening. Even high-quality data is of limited value if it is difficult to use. EHDI has several initiatives to make data more usable to inform policy and practice. Annual reports were developed by the CDC and the directors of speech and hearing programs in state health and welfare agencies that illustrate trends for screening, diagnostic, and EI rates for each state or territory. This slide shows the report of 2013 for Maine. National averages and targets are included for comparison. Reports are generated annually and provided directly to each EHDI program. All underlying data are available on the CDC website. Reports also include a case flow for all births in the jurisdiction, illustrating the flow of each child from birth to screening to diagnosis to early intervention or loss to follow-up. Another tool is EHDI Dash, an interactive dashboard reporting state and national data. It includes customizable maps and tables. States have used EHDI Dash to illustrate their own performance relative to other states. Anyone can explore the data to identify areas of success or concern. EHDI also works to inform families. When a newborn fails a hearing screen, parents may have trouble finding a facility with audiologists trained and equipped to serve infants. This can lead to loss to follow-up. EHDI Pals is an online website where parents anonymously answer a few questions about their child and receive a geocoded list of the nearest providers with equipment and training that fits their specific needs, based on a best practices algorithm developed by the American Academy of Audiology, the American Speech Language Hearing Association, and others. Iowa has cut loss to follow-up for diagnosis nearly in half, in part by targeting the quality and timeliness of data. Families needing diagnostic testing are more quickly identified and supported. In 2009, the diagnostic loss to follow-up rate for Texas was over 80%. From a public health perspective, high loss to follow-up in a state like Texas, with more than double the births of all of New England, has a disproportionate impact nationally. By expanding the use of nanny and electronic data transfers and promoting EHDI Pals, loss to follow-up has been reduced by nearly a third. CDC EHDI organized a partnership of the 5 states with the largest birth cohorts with the goal of reducing loss to follow-up through innovative strategies, including leveraging technology, such as electronic health records and electronic data exchange that are practical in states with 150,000 or more births each year. As states begin to evaluate long-term impacts, they face technological and policy challenges. EHDI programs identify the Family Educational Rights and Privacy Act and Part C regulations of the Individuals with Disabilities Education Act as challenges in conducting long-term impact studies. With no equivalent to the public health exemption seen in HIPAA, many states cannot access EI or educational outcome data. Furthermore, policies that existed when a child is screened may no longer be in place when they enter kindergarten. With multiple data sharing partners, a successful EHDI program must constantly revisit what is or is not possible based on changing permissions and management requirements. However, research does suggest significant benefits of EHDI for children with hearing loss. The EHDI Developmental Outcomes Study, funded by CDC, is a long-term project examining language outcomes. Compared to children with hearing loss diagnosed later, children diagnosed before 6 months of age had greater expressive vocabulary at age 2. This was particularly true for Spanish-speaking children. Data from the Maine EHDI program, linked with Maine Department of Education statewide testing data, were used to examine third-grade reading and math proficiency for all children with hearing loss, whether or not their hearing loss had been detected through the EHDI program. Children with hearing loss identified through EHDI were significantly more likely to meet third-grade math standards versus children with hearing loss not identified through EHDI. A similar trend, although not statistically significant, was seen for reading. In summary, surveillance programs face challenges as they follow up longer-term outcomes. This requires greater access to higher quality data from more sources, including ones outside the realm of public health. Sharing sensitive data across agencies brings additional policy barriers. However, such efforts can help families receive better quality, more timely care for their children. They can also help healthcare officials, providers, policymakers, and researchers identify policies and practices that help the people they serve, while promoting a deeper understanding of long-term impacts of services and programs. Thank you.
So we will now open up for questions, and I think we'll start with some from social media, if you have some, Susan.
What is CDC doing to promote continued screening of hearing in children during the well-child visit recommended schedule, specifically addressing the important public health issue of early detection of hearing loss beyond the newborn period?
So I'll ask Craig if you can comment on that.
Yes, I think in terms of individual states, there's a variety of programs going on where at the state level, some are trying to expand their EHDI systems to incorporate data on non-newborn hearing screen, but acquired or progressive hearing loss as well. So, but that again meets some of those challenges of you're working often outside of systems that we're typically working with newborn screening.
Another question? Oh, Dr. Shukit.
Yeah, thanks so much for a really interesting session. I had two kind of related questions. I was curious in New Jersey about whether there was a event, individual advocate that brought the law to reality. And then for the history, I guess any of you, in the 60s when the program really began, was it because the test was identified for phenylketonuria, or was it because, people were pushing that we needed to do more? I'm just kind of interested in when we get a law versus when we just think something's a good idea.
So I can address the New Jersey piece. There was a legislator that was personally impacted by a relative with a critical congenital heart defect, and that served as the impetus for the legislation.
And for Bloodspot screening, the development of the test by Robert Guthrie brought that about as initially shown to be advantageous to detect these. It had been shown previously that early detection through family history, through other affected children, one could improve outcomes because diets were developed that were specifically low. This is for people in the room who aren't familiar. The first test that was utilized for newborn screening was for PKU or phenylketonuria, where children have an inability, individuals with PKU have an inability to break down the amino acid phenylalanine, which accumulates and can cause toxicity to the nervous system over time. So treatments were developed where diets are low in the amino acid phenylalanine and then supplement an amino acid that's deficient in these individuals called tyrosine. So I think that first, there was the development of an efficacious treatment for PKU, and then through Dr. Guthrie's efforts, the development of an relatively easy screening test that could be applied at a population level, which allowed the initiation of a statewide and then national newborn screening programs for PKU.
Relatively high rate of loss during the follow-up for a baby who failed hearing screening. I see it's like 40 or 50%.
I think programs have been kind of targeting this now for a few years, and that's one of the areas of particular focus. I think going forward is reducing is to continue to reduce loss to follow-up. Some of the issues that some states have experienced is whether or not reporting is mandated, and other issues that educational communicating to providers or audiologists, for example, that they need to report cases where a child has passed their hearing screen or passed their hearing test. Some may only report cases where the child has a diagnosed hearing loss, but as we can see that for public health reporting, it's important to get the complete data on children who've also passed. It's again, some of those challenges looking outside of into a whole new arena of working with audiologists and audiological clinics versus your traditional in-hospital screening.
Another question, Susan?
This question is specific to Dr. Van Naardenbron. Kudos to New Jersey for rapidly developing a comprehensive and thoughtful surveillance program. Can you speak to the initial concerns that the clinical community had regarding added resource burden from false positives?
Well, thank you. The issue of defining false positives is a layered topic. So I mentioned there were 25 infants with CCHD that was identified because of the screen, but pulse oximetry screening isn't selective for CCHD, so we identified 19 other infants with non-critical heart defects and then 10 other conditions. So collectively, it represents 54 success stories as a result of the screen. The remaining infants were made up of infants that were true-false positives that were identified after quality control at the hospital, so there was no added resource burden, or echocardiograms that were done and yielded unresolved PFO or a PDA. What's interesting and I think compelling to us is that of the approximately 480,000 infants that have been screened through June 30th of 2016, there were only 52 echocardiograms that were done unnecessarily. Among those infants for which they failed and the diagnostic workup was done because of the screen, only 52 unnecessary echocardiograms out of 480,000 babies screened, and there were no unnecessary transfers. So I think those data to us speak to one aspect of the burden.
Up on your question, so you're talking about the successful numbers. So did you actually miss any cases, I guess?
That's a terrific question, and one that I think nationally is a part of a major discussion trying to identify methodologies for identifying false negatives. Birth defect surveillance is really an important part of that, and linking that to statewide individual level screening data. And now we've begun to collect those data in New Jersey, and we hope to look at it to get a more comprehensive picture through birth defects to identify all the CCHDs, and then having all of their individual level screening data to assess how many actually passed.
Other questions in the room? If so, please use the microphone so that those on the webinar can hear.
Yeah, hi, thanks. There are some genetic indicators for both of the point of care screening initiatives that you talked about for deafness and some cardiovascular diseases. Has CDC considered incorporating any genetic assessments into some of their screening recommendations?
So CDC hasn't incorporated that at this point. There are standard case definitions being developed for the hearing loss conditions as well as for CCHD conditions, and there are genetic associations with more strongly with some of the hearing loss conditions than with the CCHD conditions, and perhaps Marcy can speak to how that's being done through the national programs.
Thanks, Stuart. Nationally, we are looking at those case definitions, both for EHDI and for CCHD. There are a wide variety of genetic mutations that could lead to either of these diagnoses. And so that tends to be more on the clinical diagnostic follow-up rather than in the screening process. Remember, screening is really intended to identify the children who are at risk, and then as part of that diagnostic follow-up and workup, more in-depth genetic workup will probably be done and recommended.
Another question, Susan?
Could newborn screening programs be expanded to include Tdap and influenza vaccines to parents and partners before discharge?
So newborn screening is to identify conditions in newborns that could have significant morbidity and mortality if they are not detected in the early neonatal or infant period and some intervention or treatment occurs. The conditions that you mentioned seem to be standard of care conditions rather than newborn screening, because it's not clear to me what would be screened for in those conditions other than that those interventions have not occurred. So it's a different, to differentiate what is standard of care from the standpoint of the treating the infant versus screening for conditions that could have an impact if they're not identified. These are two different approaches to evaluate for conditions in the neonatal period.
I was going to follow up on one question that actually is right in line with that. So the Secretary's Advisory Committee had a lot of discussion around critical congenital heart disease as well as EHDI about whether this should be essentially standard of care practice or essentially under the rubric of newborn screening. And the part of the argument around the newborn screening piece was the urgency and the need for public health to assure for that follow-up component. So like I said, I'd love to hear your very quick, because I know we're almost out of time, thoughts about that, whether that still remains 5 years after implementation of CCHD, as well as 10 or 15 years after implementation of EHDI.
Thank you. That was not an easy question to end with. But I think it does still remain that public health importance of these screening programs. And it's only when we come together as a public health system that we can really analyze these data, determine the best algorithms for screening, and really start to assess the long-term outcome and impact of the screen.
And I think particularly is we want to look to more long-term outcomes, being able to do that public health surveillance over time, potentially pooling data across states in ways some of that we talked about, like with EHDI, and because you start to focus on smaller subsets, it allows you to look at what are the impacts on smaller subsets within the population and longer-term outcomes associated with other potential chronic disabilities. So I think it's extremely valuable to keep that forward.
And I'll just add and underscore the importance of having national and statewide data on a population basis to be able to evaluate those questions specifically. In New Jersey, one of the pearls that we found was that having a statewide mandate to do the screening was actually crucial, and there was a lot of education that needed to be done delineating standard of care and clinical monitoring versus pulse oximetry as a public health screen. And so I think there's been tremendous benefit with that education, but having it be a systematic screen in and of itself.
So let me just add one thing that I think is really critical, and that's the disparity issue. Even though it's standard of care, there's clearly going to be populations that fall, between the cracks. So that newborn screening really does, from the front end, assure that everyone receives that service.
Thank you all very, very much. A great Q&A session as always. Let's have one more hand for our speakers, please. And please join us in October for the next session of Public Health Grand Rounds. And don't forget to fill out your survey online.